All right, today we're diving into ADHD treatment, but we're not going to talk about the usual suspects. We're looking at a totally different class of medication, one that for a lot of people might actually be a much better fit.
So let me ask you, when you think about ADHD meds, what pops in your head? It's probably Adderall, right? Or Ritalin? And yeah, those are huge, but they're really only one side of the coin. What if they don't work for you, or the side effects are just too much? Well, it turns out there's a whole other playbook.
And that's exactly what we're jumping into first. We're going beyond the stimulants to explore this other approach, an option that's become absolutely critical for a lot of people trying to manage their ADHD.
Okay, so you might be wondering, why would someone choose a non-stimulant? Well, the reasons are actually pretty powerful. First off, they're not controlled substances, so that whole risk of abuse or diversion, gone. They're also a lifeline for folks who either don't get results from stimulants or just can't handle the side effects. And here's a big one. If you're also dealing with something like anxiety, these can be a much better choice.
All right, so if a non-stimulant is on the table, what exactly are we talking about? Let's break it down and get to know the two main teams on the field here.
So you've got two major groups, norepinephrine reuptake inhibitors, or NRIs, and alpha-2 adrenergic agonists. I know, mouthfuls, right? But here's the key thing to know. They both work on the same brain chemical, norepinephrine. They just do it in different ways. Think of the NRIs as kind of like a dam. They keep more of that focus chemical, norepinephrine, available in the brain. The alpha-2 agonists, they're more like a dimmer switch, fine-tuning things to help control hyperactivity and impulsivity.
And here are the actual names you might hear. On the NRI team, you've got atomoxetine, that's Strattera, and vilazazine, which is brand name Quellbri. Then for the alpha-2 agonists, you'll see guanfacine ER, or Intanuv, and clonidine ER, which is Capave. So yeah, these are the main players a doctor would likely talk to you about.
Okay, so we know what they are, we know their names, but the million-dollar question is, do they actually work? Let's dig into the evidence.
Take a look at this chart. It's from a huge meta-analysis, basically a study of studies. Now that term, effect size, it's just a fancy way of saying how well does it work. As you can see, long-acting stimulants, yeah, they pack a big punch, high effect size. But look at the non-stimulants. They have a solid, moderate effect. And here's what's crucial. That's way better than a placebo. So while they might not be as potent as stimulants across the board, they are absolutely an effective treatment.
And the researchers pretty much spell it out for us. They say, yep, there is a significant difference in the average effect size. But let's be super clear about what that means. It doesn't mean non-stimulants are weak or don't work. It just means that on average, stimulants have a stronger effect. The most important thing always is finding what's going to work for your specific brain and body.
But of course, with any medication, there's always the fine print, right? And this part is really important. We've got to talk about the risks and the side effects, and this is exactly why having a doctor guide you through this is just, well, it's not optional.
So some of the common things you might feel, especially when you're just starting out, are things like drowsiness or fatigue. But here is an absolutely critical difference between the two types. The NRIs, like Strattera, they can actually increase your heart rate and blood pressure, a bit like stimulants do. But the alpha-2 agonists, like Intanuv, they do the opposite. They tend to lower them. You can see how that would be a massive factor in deciding which drug is safer for someone.
Now, whenever we're talking about long-term meds for kids, one of the biggest questions is always about growth. And this is data straight from the FDA's label for Strattera. You can see it right there. There's a noticeable dip in the average weight and height percentiles after treatment starts. Now, the good news is it does tend to bounce back over a few years, but this really drives home why a doctor has to be keeping a close eye on a child's growth charts the whole time.
Okay, so we've talked about the expected side effects, but sometimes the biggest dangers aren't from the drug itself. They're from how it interacts with other common medications. And I want to show you a real-world story that shows just how scary this can get.
Check this out. So you've got a 26-year-old guy. He's been stable on Strattera for years. Everything's fine. Then his doctor prescribes him Prozac for a completely different reason. Here's the problem. Prozac basically threw a wrench into the works. It blocked the specific enzyme his body uses to clear out the Strattera. So what happened? The Strattera levels in his body went through the roof. We're talking 5 to 8 times the normal dose. And the result was terrifying. He started having dangerous cardiovascular problems, even fainting. It is such a powerful reminder that you have to tell your doctors everything you're taking. So what exactly happened there biochemically?
It was something called a CYP2D6 inhibitor. Let's make that simple. Think of CYP2D6 as a little cleanup crew in your liver, responsible for getting rid of certain drugs. While some medications, like Prozac, are inhibitors, they tell that cleanup crew to take a break. So if you're also taking a drug like Strattera that relies on that crew, it just builds up and up to toxic levels. And what's really wild is that about 7% of Caucasians are just born with a slow-mo version of this enzyme, which makes them naturally more susceptible to these kinds of interactions.
Okay, so we've looked at the good, the bad, the risks, all of it. How does anyone actually make a decision? In our last section, let's pull all these threads together and figure out where non-stimulants really fit.
So, let's recap. When might a non-stimulant be the right call? Well, if a patient just can't tolerate the side effects from stimulants, like insomnia or no appetite, it's a great option. If there's any concern about substance abuse or diversion, it's a much safer path. They're also a go-to for people who have coexisting anxiety or tic disorders, since stimulants can sometimes make those worse. And finally, for anyone with specific heart conditions, a non-stimulant can be a way to avoid poking the bear, by not messing with heart rate and blood pressure.
And the decision isn't always purely based on what's best for the patient's brain chemistry. Let's be real, insurance companies have a huge say. A lot of the time, they'll make you try a cheaper, generic option first before they'll even consider covering a more expensive brand name. It's just a practical reality of navigating the healthcare system.
So, what's the big takeaway here? We've seen that there isn't just one way to treat ADHD. There are these completely different classes of drugs with their own unique ways of working, their own risks, their own benefits. It really makes you wonder, right? Maybe the future of ADHD treatment isn't about finding the one best pill for everyone. Maybe it's about getting way more sophisticated, designing a truly personalized plan that's tailored to a person's individual genetics, their other health conditions, their whole life. What do you think?